colonization ज़्यादा important.
Basically, we want to know whether you should or you should not start a particular patient. You need some proof. One of the fungal
Good evening, everybody. Before starting, I want to tell you some interesting fact about the fungal infections, and it is the most populous kingdom on the planet, the most ancient, enormous, and incredibly resilient. It is also known as a medical miracle workers, and raw mushrooms are inedible. It can be used to make paper and clothing also. So fungal mycelium can be used to light up the dark, and it is not even close to being a plants. They have invented the internet before we know it, and eating some fungi makes us smarter. No, but scientists have published it like they are going to increase the IQ levels, but it is not proven. So fungi could save the planet. So in the introductory part, fungus can be divided into the yeast or mold, and they can be growing into the soil, water, fruits, jelly, refrigerator, humidity, and dry climate. So from bread to your beer, fungus is the main component. So can you name some antibiotics which are made from the fungus? Penicillin. So fungus are not a plant, not animals, and brief classification for the fungal pathogens are yeast and molds. In yeast, yes. In the yeast, you can say Candida species, and in molds, it may be septated hyphae or aseptated hyphae on KOH mount, as one of the resident told. And in septated, we can see the main important is the Aspergillus, and in aseptated, it is a Mucormycosis. So for morphogenesis and virulence, fungus are dimorphic fungi which can change their shape from according to the environment and according to the temperature and according to the site of infection. So they can change their shapes from hyphae to yeast and from filamentous to conidia. And there are some opportunistic fungi which are using this technique for their virulence, like Cryptococcus, Aspergillus fumigatus, Histoplasma, and Paracoccidites. Coming to the immunity, so once there is an invasion of the fungal mycelium, after that, first natural immunity comes into the action with neutrophils followed by macrophages, and ultimately the adaptive immunity comes into the role with T helper cells 1, T helper cells 2, and T helper cells 17. for the fungal infections. So the most common cause of invasive fungal infections, according to the literature, as per of now, are the Candida for 70 to 90% of infections and 10 to 20% in for the aspergillosis. So invasive fungal infections, if you see the data, so for medical and surgical ICU are most commonly with the Candida. Then solid organ transplant or hematological patients are with aspergillosis, and in oncology patients we can see both of them, candidemia and aspergillosis. So coming to the incidence and mortality, you can see the critically ill patients having the attributable mortality of 63% with invasive aspergillosis and 46% with invasive candidemia. So invasive candidiasis in ICU with Indian data, limited data is available, but it is a highly alarming data. So we can see around 400 cases in 1600 bedded tertiary care center, contrast to the 300 per year in the Australian ICUs. So attributable mortality is very high. It is around 36%, which is a 2009 data, very old data. So coming to the data from India, with 4 hospitals like Sir Gangaram Hospital, it is showing like 11.5% with the Candida albicans, and Safdarjung Hospital with 48% of Candida tropicalis. In SGPGI, it is around 33% for Candida albicans, and AIMS like 39% with tropicalis, and PGI Chandigarh with 42%. So these are the various sites for the candidemia, candidiasis: ocular, CNS meningitis, oropharyngeal, cyanopulmonary, cutaneous, genitourinary, and subcutaneous. So what happens if we start delayed antifungals? So if you consider comparing with the bacterial infection, like if we delay after having sepsis and septic shock, if we delay antibiotics for 5.5 hours, the survival for the delaying in the 12 hours antibiotic therapy starting, survival would be 16% compared to the Candida, which is only 7% of survival. So we have to take it seriously if the patient is having bloodstream infection with the Candida. So these are the diagnostic method for the diagnosis of Candida infection. We can diagnose it by the culture, histopathology, HRCT scans, beta-D glucan, galactomannan, and PCR technique. Of them, PCR gives you results within very short time, and galactomannan and beta-D glucan are highly false positive. Can anybody tell me the false positive results with the galactomannan happens in which situations? Piptas. Okay. So risk factors for the invasive fungal diseases in critically ill adult patient, it was a systematic review. So there are some clinical prediction rules which are developed over the period from 90s till now. In 1994 by Pittet et al., in 2005 by Papio, in 2006 Leon et al., and 2007 Ostrowski. In 2006, it was a bedside Candida score given by the Leon et al., which is very useful for all the physicians because it is very easy to remember. So I will just show the bedside Candida score by Leon et al., not all the scores. This is the bedside Candida score. It is giving the points for 1 for TPN, 1 for surgery, 1 for multifocal colonization, and 2 for severe sepsis. If the score is more than 2.5, you can start with the antifungal therapy without having cultures. So what are the antifungal therapy strategies which you use in the ward or ICUs? It may be prophylactic, it may be empiric, it may be preemptive, or it may be targeted. There are only 4 strategies, of which first is prophylaxis, which is your fear driven or having risk factors. Empiric is fever driven. With risk factors and fever, you can go with the antifungal therapy. What is preemptive? Preemptive is evidence driven. And what is targeted? It is a diagnosis or culture based. So briefly, I will summarize the antifungal drugs and their mechanism of action. And for cell membrane, you can see azoles act on the cell membrane. For cell wall, echinocandins act on the cell wall. And for intracellular, you can see the flu-cytosine, griseofulvin. And cell membrane, I forgot amphotericin B. So what are the common toxicities with the antifungal therapies? You can see there is a liver enzyme derangement with amphotericin, renal toxicity with voriconazole, amphotericin, CNS toxicity and ocular toxicity with voriconazole. You can see with the start of amphotericin, patients can have rash, allergic symptoms. With azole drugs, there may be a GI upset and QT prolongation with azole drugs, infusion reaction with amphotericin, and bone marrow suppression with amphotericin B. So, can anybody tell me hematology resident any? So, what dose of amphotericin B may cause the anemia to the patients? After how many dosage or cumulative dose? Anybody from hematology? So amphotericin B cumulatively, if we give more than 2 grams, then it will start to decrease the erythropoietin synthesis. Then it will cause the anemia. So this slide shows the spectrum of antifungal drugs. And what you have to remember is in Candida parapsilosis, the echinocandins are not good. In Candida glabrata, azoles are resistant, and in mucorales, echinocandins are not good, and in Cryptococcus, echinocandins are resistant. So you have to just remember, you don't have to mug up everything. So prophylactically, if whatever we are left with the treatment options, if prophylactically you can start with the fluconazole therapy. If preemptively with fever and risk factors, you can go with the echinocandins and liposomal ampo till the cultures are available. And empirically also you can start with the same. If the patients are in shock, echinocandins are preferred because the volume of distribution is highly increased in septic shock patients. And for targeted, for candida infection, you can go with the echinocandins, liposomal ampo, and fluconazole. For aspergillosis, voriconazole, liposomal ampo, and echinocandins. And combination therapy like caspofungin and voriconazole or liposomal ampo, you can use. This is the pharmacokinetic and pharmacodynamics for the antifungal therapies for invasive candidiasis. And polyenes are mainly fungicidal drugs. Azoles are mainly fungistatic, echinocandins are mainly fungicidal, and flu-cytosine is mainly fungistatic. So for dosing, what you have to remember, there is no dosing alteration for echinocandins in renal failure patients. There is a dosing alteration for renal failure patients with azole group, and there is a no dosage adjustment for the echinocandins and liposomal amphotericin B. So to summarize antifungal dosing, you have to do therapeutic drug monitoring, which is not available with our institute, for azole group of drug and flu-cytosine. For others, you don't have to do the therapeutic drug monitoring. So another is the Candida Oris. It is a global threat. So Candida Oris, there was one literature paper from Indian ICUs. From our institute, Romi Marak ma'am has contributed to that. And they have identified the major risk factors for the Candida Oris infection, which is a longer stay in ICU, underlying respiratory illness, vascular surgeries, medical interventions, and previous antifungal exposure. So pharmacodynamic optimization for treatment of invasive Candida Oris. And so your first choice would be echinocandins for Candida Oris infection. If it is an infection, if it is a colonization, just remove that device like a Foley's catheter or tracheal TT tube, and you can just check for the another surveillance culture. So what they have seen that micafungin has produced the most killing among the three classes of the echinocandins. So these are guidelines for the identification and treatment and prevention of the Candida auris. So Malditop is the method of choice for the correct identification of Candida auris. Otherwise, it will be misidentified. And there should be infection control practices in place like hand hygiene, removal of the unnecessary medical devices from the body, and the screening should be performed to identify the colonization, and all education to the all healthcare personnel, including staff working with the environmental clinical services. And there should be antifungal stewardship in place. So to summarize, invasive fungal infection in ICUs increases the morbidity, mortality, and cost to the patient. Delayed diagnosis is major impediment to the early initiation of antifungal. Clinical prediction rule plus biomarkers can help you a lot. Antifungal resistance is rising. Candida auris is a rising menace. And antifungal stewardship, environmental cleanliness, hand hygiene, and contact precautions may be the only the viable options left. Thank you.